Well, welcome to Functional Roots, where whole body wellness begins in the mouth. I'm Amanda.
And I'm Heather, and we're hygienists with a passion for holistic, functional, and naturopathic.
This isn't your average dental podcast. Around here, we dig deep, past the plaque, and into the powerful connections between oral health, the body, and the way we live.
So whether you're a fellow dental professional, a wellness enthusiast, or just someone curious about a more natural approach to your health, you're in the right place.
So grab your favorite herbal tea, settle in, and let's get to the root of it all.
Right. Yay. Okay.
So today we are joined by Tricia Rogers, MSCCC SLP, and she's going to tell us all about that. But she is an ASHA certified speech language pathologist with nearly 30 years of experience. For more than 2 decades, she has specialized in assessing and treating individuals with orofacial myofunctional disorders, working with children to improve breathing, oral rest posture, and overall oral function. Alongside running a private practice, Tricia mentors, presents, and consults with professionals nationwide. She is also the creator and author of Miss Tongue and Friends, a children's book series designed to make myofunctional concepts simple, fun, and engaging. These books are now being used by therapists, educators, and families as practical resources to support healthy oral development and lifelong habits. Through her Miss Tongue, not Miss Tongue-Tied, and Friends book and learning series, Tricia is bringing these important skills to children around the world in a way that feels playful, approachable, and empowering. Welcome. We have not had a myofunctional therapist yet on our podcast, so we are excited to talk about this very exciting, very pertinent field, a beautiful way for hygienists, dental professionals to really support and look kind of beyond the mouth, well, very focused on the mouth, but beyond the mouth, and really support whole body wellness. So we're excited for this conversation, so I'll give you the floor to start.
Yeah, so excited. I'm going to start with just the first question. We'll just lay down a foundation of who you are and how you get started. So tell us a little bit about your process of getting into speech language pathology, myofunctional therapy, disorder, and how you got to where you are. And what you're doing now. So just kind of give us a little base, Trish, on myofunctional therapy, because we have not covered that. Speech pathology, what's the difference, and why it's so important.
Great. Oh, and again, thank y'all for having me here. I'm so excited to talk about myofunctional therapy with you and introduce it to your audience. Okay, so I am a speech language pathologist. And so my early work was with children who had a motor or movement component to their speech disorders or their speech. So it was a really easy segue for me to move into having the training in myofunctional therapy, because I was early on learning about like the tongue position and how important it was for the speech. And so adding the breathing and the lips closed for at rest was just like, it just put all the pieces together for me. So, and honestly, I always say this, I have been doing myofunctional therapy before it was cool. Like now myo is the thing. It was a struggle to get insurance. I ended up going into private pay only because I've been doing this work since the early 2000s. So I've been doing it a long time. And so I was like, I need help with doing this with my patients and being beholden to the insurance. It was just like, oh, I had to take a step back at the time. So, but this was years ago. So I'm happy that it is much more, getting much more known and used by OMT, myofunctional trained professionals, which are speech language pathologists and registered dental hygienists. The both of us are doing it. The one difference between, so let me back up. Myofunctional therapy, what is it?
Yes.
Basically, it is like I have a definition. I'm going to read it because the definitions of myofunctional therapy are wide and vast and a lot. but I talk about it being like you have disorders, myofunctional disorders or OMDs, that are habits, conditions, or patterns that affect how the oral facial muscles rest and function. Okay, often affecting facial growth, sleep, breathing, airway, desirable resting postures, chewing, swallowing, and speech production. But that's a big, I tried to sum it down into a little definition, but still, it's about, can the child or adult breathe through their nose, airway? And if they can, how do we position the lips and the tongue and the jaw to support nasal breathing? And as we know, nasal breathing is much healthier than mouth breathing. So
Yes.
that's that.
Great recap. That's amazing.
Good.
And it's kind of fun because all of the myofunctional therapists that I know are hygienists. So you're the
Mhm.
first one that's on the speech pathology side of it. And oftentimes we have in schools a speech pathologist that's dealing with the littles in like 4K, 5, 6, 6-year-olds to
Mhm.
deal with the slurs and pronunciation. That's what I
Mhm.
think about as,
Mhm.
but then it's interesting. It'd be awesome if we had the myofunctional therapy component also
Mhm.
involved in those school screenings,
Right,
because whew,
right,
it's
right.
uh it's more than just the lisp.
Absolutely. And part of what I'm doing now is I have been doing is supporting the school SLPs, because school SLPs are bound by things that are educationally impacting. And so how can we bring myofunctional therapy components to the schools? And it's possible. And I'm working, we'll talk later about again more about my books, but I'm working on a project where the books support the school age versions of speech clarity. Okay, so there's function in speech, but there's also function in swallowing. And also the difference in myofunctional trained professionals, RDHs and SLPs, the one difference is because we can work on the speech that is often impacted by the tongue position, right? And we also take swallowing beyond the oral prep aspect, and because of the disorders in swallowing like dysphagia. So like when swallowing is a health and safety risk, we also can work on that. So that's how SLPs got into the mouth in the respect of function, right, in swallowing and chewing and breathing. And because we also need breath correct, the circle breathing for speech when we talk.
Mhm.
Hmm. Yeah.
Dysphagia, can you kind of like go a little bit into that? Because I mean, we're all talking about the nasal breathing, the tongue tie, but the symptom of choking, and I know chewing is so important, and
Yeah.
we're stuck in putting kids on soft foods or mush,
Mm-hmm.
Hmm.
which causes issues with the facial structure development. Uh, so is how do we flag parents or hygienists or anyone to see the dysfunction that you might be talking about with dysphagia, and how and then where to go from there as far as what that's showing us without having fear of our kids choking, because we need them actually to stop eating baby food
Right.
and chewing food so that we have good facial development in
Yes.
that
Oh,
concept.
I love that. Okay, so I'm going to talk about the chewing aspect before I talk about dysphagia,
Okay.
because yes, because chewing, that's where we definitely with the facial. So a lot of my kids that come in, and what dental hygienists can do and parents can do, a lot of the kids will come in and they are not using their back molars for chewing. I had a kiddo just the other day. He had been through myofunctional therapy and for like 8 or so sessions, but no one had talked to him about, or the parent about the chewing. And when I asked him, I pulled up my little, mouth right here that I have, and I'm like, "Can you tell me which?"
Not a little mouth,
Yeah,
not a
no, it's
little
not
mouth
really
at
all.
all.
I
It's like
need one of those.
it's one of the big ones. And so I asked him, I was like, "Can you tell me which of the teeth you're using for chewing?" I was like, "Is it the ones in the way back or the ones kind of in the middle here?" And he's like, "Well, it's the middle ones." And so then it prompted a discussion with mom. It's like, okay, his tongue is able to lateralize. There's no restriction with his tongue, but he's just not learned how to chew or been taught to chew with his back molars for whatever reason. And his jaw is not, uh, it's got excessive movements around, and he's excessively chewing, right, on objects that are not food, non-nutritional chewing. um so between not having the tongue resting up on the mouth for input and also that no chewing, so I cannot tell you how many times I have to talk about chewing, and chewing is so important. Now, this is
Can
with a
we
kid.
camp there for 2 seconds?
Yes, please.
Like this is honestly a question I've never thought to ask a patient.
Yeah.
Where are you chewing?
Yeah.
Ask this. I'm
Hold the
so glad.
phone.
I know. I'm so glad this came up because it's like, yes, and the little ones will tell you, like, point to the teeth that you use for your chewing,
Huh.
and they'll like, and it's amazing. And if you can't get that information in the chair, have the parents get that information for you because they can, and then you can explain to them why it's so important. But oh my gosh, that with chewing, and also the parents may not understand that chewing with their mouth open is not a manners thing. It's because the kiddos cannot breathe through their nose.
Mhm.
That is really so. Yes, all anyone that's in the mouth, ask, where do you chew? Where do you chew your food? They'll tell you. I
I
have not.
think
And then how do you train them to chew on the molars?
I
Oh,
know. This is
it's
a
the
whole
best.
thing.
It's the best. Okay, you ready? Now, forgive me, and maybe you and y'all, all of us can talk about what we can use better than I say. The Harbo gummy bears, HARB. Okay, they don't.
Oh, we know.
Okay,
We
okay,
know. We know a
okay.
good gummy.
Okay, they don't stick to your teeth.
Okay.
They don't stick to the teeth, and so
Okay.
you have the kiddos put those on the back molar and have a contest with family members to see who can chew the longest with the back molar.
Hmm.
That
That
is
helps.
like a go-to that I use all the time. The kids want to do it because they get gummy bear chewing time,
Yeah.
right? The parents, like, it's easy to get those gummy bears. I should, like, buy stock in it because I use it all the time. I don't, but I should. And then and it's amazing.
Hmm.
That's
Just
it's interesting thinking about it. Obviously, from the dental hygiene's perspective, we're taught, put sealants over the pits and fissures of those molars, but it would kind of make sense. We're eating a softer processed diet, so there's going to be more fermentable carbohydrates. It would make sense that there's more decay possible because there's not the self-cleansing mechanism happening if they're not chewing properly on those back molars. That's just where my mind is right now.
yes, I
Even though I
agree.
know like we're probably like, oh, chewing sugar is like dying, but let's just be real. If like that's the worst thing a kid has, that's we're doing great with a Haribo gummy bear,
Right,
but
right.
not
Which
sodas and all the other things.
which is a brilliant point out. And we know that because if we have someone who's missing molars and then they're not chewing, we get calculus built up around the opposing ones because
Yep.
there's no function there. And
Yeah,
chewing is cleansing
yeah,
Yes,
in
chewing is
nature.
cleansing.
Yeah.
Yes.
yeah, yes. And I do often use some of you. Have y'all heard of chewy tubes? Those type of not they're like in the world of speech and oral motor and sensory. There are these things called chewy tubes of all different types. And I'm using a brand name right now, but you can have the kiddos chew on this plastic thing on their back molars. Okay. But I find that using food is much more functional, right? And motivating for kids.
Yeah.
But I was wondering, like, if there's no back molars back there, and they're not coming in, can you stimulate that with a device or a tool for chewing a little bit until the molars come in? Or would the Harbo gummy bears be fine too?
Just, have some fat beforehand, right?
There, there you go.
It's fine. It's
Right?
fine.
Love it. Now, and to segue back to dysphagia,
Yeah.
dysphagia is an area even where I'm not specialized in it, but I know to recognize it because it's like when you would aspirate and swallow and have get pneumonia, aspiration pneumonia.
Mhm.
And in those cases, unfortunately, you may have to have pureed foods and other liquid, thickened liquids and things like that in order for the child or adult not to
Aspirate.
aspirate. So, but I will say, I'm knowledgeable enough to know with a patient like I just saw it that they were having dysphagia and it wasn't just an oral myofunctional issue. And referred them on for the specialists that deal with dysphagia. And it's good for your audience, my dental hygienists, to understand what dysphagia is and be able to recognize it, that it is. And so there's a lot of research out there about dysphagia, but that's an area where it's speech pathologists and specialized training in that, and kids and adults alike. Yeah.
And it's
Hmm.
the inability to swallow appropriately.
Yes.
And then you aspirate.
It's so it's an interesting way to put this. So the kids with myofunctional therapy, they are not swallowing correctly or functionally, right? But these kiddos typically have the muscular abilities to do it. We just have to train the way that they're doing it rather than, the horizontal, there's the vertical way. When you have dysphagia, you neurologically have impairments that
Okay.
cause safety issues.
Okay.
And you can aspirate on your own saliva.
Okay.
Yeah.
Are
Yeah.
those
Great.
neurological issues like a developmental thing, or what's kind of the biggest reasons for the dysphagia?
Oh, good. So Parkinson's can cause dysphagia.
Oh, yeah.
A stroke can cause dysphagia. A client that I have that has bell palsy.
Bell's
Bell's
palsy.
palsy.
Not bulbar palsy, excuse me,
Oh.
bulbar, which is like bulbar palsy.
Okay.
A
Both
kiddo.
me and Heather. Bells.
Yeah, this is
We
what I
know
said
this
too, and I
one.
was like, yeah, I know that. No, that's why I had to go bulbar palsy because I went Bell's palsy. And then uh, like a child who has compromised, like a child with cerebral palsy could have swallowing
Yeah.
any with any motory sensor component feeding disorders, that kind of thing. So that literally is out of the realm of what we as oral facial myofunctional therapists, professionals are trained. But you need to recognize it to know, hey, they're not swallowing correctly, but also, oh my goodness, they're not swallowing. Like
Yeah.
there's a 3-second delay in the swallow of this water that's supposed to go down or yeah. And again, it's not my area of expertise, although I did work in it early in my career, like the first year, but had some training, but not part of my
And
functional therapy.
I have a question with the tongue dysfunction
Yeah.
and chewing. You kind of said like chewing with our mouth open is a clinical sign, or we have someone chomping and gasping as they're eating because they're not able to breathe through their nose. That's kind of a sign of dysfunction of the tongue and lack of issues, in that concept. Is it true too that it's not out of laziness, but it gets hard to chew and the tongue, and you swallow before you're done actually chewing,
Okay.
right?
Great. Yes. That is definitely a functional task. And if you think about it, chewing and swallowing is a lot more difficult than we think when it's just so simple for us. Like we don't, it's one of the things we don't really think about. And y'all are correct. There are a lot of kiddos that will chew 3 times and then swallow it whole. And that is can be because the tongue is restricted and cannot keep the food on the back molars to then be able to mix it with the saliva and get a bolus that's not scattered, but a little ball to swallow. That can be one reason why that's a trouble. Mouth Open mouth chewing um, is directly connected to the inability to nasal breathe at times, because if you're trying to chew with your mouth closed, you are closing the only area where that person is able to breathe. So they're going to have their mouth open, breathing through their mouth while they're chewing. Well, so it makes sense that 3 seconds without breathing is a long time. So you're going to chew, and then swallow so you can breathe. Mm-hmm.
Awesome.
And did I answer everything about
Yeah,
that?
yeah, it was
Okay.
a
Yeah.
good start. Um, so what was the moment, or did you have a patient early, where you realized that breathing, oral posture, function, and like where was that connection for you with the speech pathology going into the breathing, oral posture, tongue
Oh,
function?
oh, great. So I think it was early on, like I said, I had training in about the tongue posture, and I was really following that methods in my training. I worked with a kiddo for a long time. Okay. So he had apraxia, which is a motor planning issue that causes extreme unintelligibility. He was an extremely bright child. I started working with him when he was 2. And so we got to where he was, I'll try. I was with the family for a long time, where he was like 10 to 12. Okay. And he was very intelligible. Now we'd gotten through all that motor planning that was the brain talking to the tongue issues, and he was intelligible, but it wasn't that crisp and clear. And just uh, knowing that you can't just separate, I couldn't just separate apraxia and the speech component when I could tell he was breathing with his mouth open. So therefore his tongue was down. And so the efficiency when the tongue is down in the mouth, right? Okay, here we go with my mouth. The tongue is down in the mouth, and you need all the speech sounds are made with contact of the tongue in some fashion with the upper palate, right? And so if the tongue is down here and you're seeing it, the efficiency is incomplete, is not great. So I realized to clear up his his clarity, when we got the tongue to rest on the roof of the mouth, the lips were closed, then all the motor planning issues we'd worked on and that had gone away made the speech even more clear and crisp, just because having the tongue resting in the position against the palate. So it was like super easy for me to see, oh my goodness, like this is a game changer. And so at that time I was doing my training for oral myofunctional therapy anyway, and he just stands out as the case when I thought it was one thing, but it wasn't just one thing. It was because at that point, the OMD, the myofunctional disorder, was affecting the clarity of the speech.
Yeah. So he had a tongue tie. So let's talk about tongue tie. Let's talk about what the myofunctional therapist does. So we haven't really talked about what myofunctional therapy is. When I'm talking to clients and kind of introducing the concepts, I kind of say it's like the physical therapist for the tongue, assessing tongue tie, lip ties, function of the tongue, and the lips, and making sure that all of that is working. I work with a lot of adults, so I do the little, like, if your tongue is supposed to be your palate, because I'm dealing with sleep apnea patients
Right,
this later.
right.
We'll get to that later. But
Yes.
you know, if our tongue is here, and it, you know, and if my tongue is tied down into the airway, right, I got to get the tongue up. So, but can you explain tongue tie, the different types of tongue tie? Because you can have an anterior tongue tie and
Right.
a posterior tongue tie, where the lip tie kind of plays a role in that. And then why is it important for us to keep the tongue up? And how does the myofunctional therapist work on some of that?
Oh, I love this.
A
Okay.
lot. That's a lot.
Yes, yes, that's a lot and I love it. Okay, so tongue ties. So there is an anterior where it's really, really far in the front, and you can tell. And there's also we're calling it it's starting to be called mid tongue tie as well now. Okay, so Dr. Zaghi has been talking about it because the middle part of the tongue is kind of like the posterior. So posterior mid tie, okay? And then you're actually correct. Whereas if the tongue is low in the mouth and it cannot elevate, then it's going to potentially block the airway, especially if you have a situation where the tonsils are large because and there's no ability to breathe through the nose, so everything, so you've got this small space that the tongue can like block, right? So yes, that is, so how do we deal with that in therapy? So you assess uh, the range of motion of the tongue and compensations. And this is a piece that is sometimes missed. Like, if you can elevate your tongue, like I can elevate my tongue, say it's tight here, I can elevate it if my jaw is closed because the tongue is pulling up the jaw. So it looks like I can elevate my tongue, but really it's like my mouth isn't open enough to really elevate the tongue tip. So that's a compensation of the jaw being closed and the tongue tip, yeah, it's up. The old idea of, well, they can stick their tongue out, that's not helpful. That's not functional, right? So you want to know, is there movements and range of motion, and are there compensations that are making it look like the tongue can move better than it can?
Yeah.
So let's see. So can you remind me another part of the question? So we're talking about tongue ties and how,
Lip tie.
okay, lip ties. So what I mostly will see with that is that the frenulum, the labial frenulum is really tight and short, so it makes it very difficult for that lip seal to happen. Okay, so there's a lot of compensation, again, that word, of the facial muscles to try to close and keep that together. So if it's difficult to do and you have the not as good capability, then trying to make it a habit is going to be very challenging. It can be like, it can be uncomfortable to try to keep it like that, lips closed, when your body and your face doesn't really allow for that. So yes, looking at lip ties is important, is very important as well.
Is the upper frenulum, that's obviously the most important. So as hygienists, when we're pulling it up, if there's like a paler pull between 8 and 9, or E and F, that's important. How thick it is and how far down it comes
Mhm.
is a good thing to kind of look at. But what about lower tip lip tie? I have a hygienist who reached out this week. She's had ortho, and when in ortho, we kind of push the teeth out a lot of the times instead of expanding in the old way. And then that can cause thinning of the bone. And we get recession down here. And I was like, can you just send me a picture? And she's got a lip tie here,
Mm.
right where the recession is. It's like, well, one, the ortho kind of pushed your teeth out, and now we have thin bone and we have thin tissue. So that's, we can't fix that
Happening.
problem now.
Yes.
But and then two, we have a lip tie that's now affecting the tissue because it's it's pulling every time we're
Mhm.
moving on the
Mhm.
lower, but does that lower lip tie or these side lip ties also play a role in the function in myofunctional therapy? Just out of curiosity.
Oh, yeah. What a great question. Yeah. So I have a adult patient right now that she has lip and tongue and cheek restrictions. And it's very hard for her to keep her lips together. And she's got a lot of TMD pain or TMD issues, a lot of jaw pain. And so her palate is not wide enough for the tongue to be released at this point. Okay. And so you don't want to release the tongue if the palate can't accommodate, because then you're going to create more issues with airway potentially, which I've seen often, unfortunately. Um, so therefore, but in her case, because she's got so much discomfort and pain and she needs to, close her lips so she can breathe through her nose, I actually encourage the functional dentist to release the lips and the cheeks before we do the tongue, for just for that reason, because it's like in her case, I she's going to get a lot of relief, and less like her mentalis muscle, because of the low, is just really really tight and it's pulling, and then it just affects, because the lip muscles are actually face muscles that are connected. So it's just like there are cases in that I have seen and right now that it is important to pay attention to that, and yes, um, those restrictions need to be considered.
Yeah, and it also has to do with not just the muscular, but the fascia.
Yes.
Yeah,
Oh, yeah. Love to talk about fascia.
yeah,
This one, another particular client I sent to have um, myofascial work done, because it is so important in the process. I was like, this is what your tongue needs to do, but right now, I want you to spend your time and energy with the myofascial release provider that I know in town, because you're going to get the best relief for that, especially while you have your tongue in the right position.
okay, let's talk about
Oh, so
myofascial
much.
therapist because and this could be a massage therapist. I'm trying to get my daughter who's in massage therapy to maybe think about going into this. But the myofascia, right, is the elastic tissue. And it's part of the muscular and the connective tissue system, and it's
Yes.
all connected. So can you explain what a myofascial therapist might be doing to help with that component?
Yes. Okay. So I'm going to just say this so I can get it right. Myofunctional therapy and myofascial release. Okay.
Yeah.
So myofascial. So you're right. The fascia covers all of our tissue. Is a like connective tissue, or like a web that covers all of our muscles and just everything. So yes, part of the healing and work that we do after a tongue tie release has to do with helping the fascia stay healthy. Okay, so you are also correct that a physical therapist or a massage therapist, even a speech language pathologist possibly can do fascia work. It is a whole nother specialty training.
Mhm.
But I find that when you have the fascia balanced, for lack of a better term, because it can kind of balance, it helps with the posture, which then helps with the ability for these getting together new patterns and habits with your muscles. So it is one of the interdisciplinary team members are the body workers that include chiropractors and myofascial release uh, uh, professionals. This was one of the questions we were talking. I am so a huge proponent of interdisciplinary work. In fact, I presented in October with a orthodontist at the Western Orthodontic Conference about collaboration and the importance for function and structure. And in my own practice and in my own world here in Portland, Beaverton, Oregon area, I have a team that includes all of the people that we're talking about.
Awesome.
Mm-hmm.
Yes, yes. And
And
it,
the chiropractor is important
yes,
because as
absolutely.
we're going through that process, we have bones that are moving, and
Mhm.
especially in the little guys, it's nice to have the ability to make some adjustments to help with that component on the structural bone side of things
Yes.
to assist the fascial release and the tongue tie release.
And the resting postures as well. Absolutely.
Yeah,
Absolutely. And the reduction of pain.
yeah,
I mean, truly, because a lot of muscle pain is partially and strongly affected by fascia
yeah.
restrictions. That's why they call it myofascial release, because they're releasing restrictions just like the tongue restrictions, but only in like the web fascia, like organ that we have. I think I
Yeah, I
okay to
saw
call it
this
an
really
organ.
cool demo of a lady like talking about, and there was a guy in a suit
Yes.
that shows the fascia, and she was like, she pulled like down in the chest area. Like if I pull all the fascia in here, it pulls you this way,
Mhm.
and
Mhm.
then it throws your entire posture out. And just an FYI, fun little fact, the
Yes.
fascia of your tongue reaches all the way down to your toes.
Mm-hmm.
So we have to pay attention to the tongue for posture, which the side effect of doing myofunctional therapy and this work is much better posture.
Right.
And someone
Overall.
posted a picture the other day, and the facial changes in the boy that she posted were phenomenal because we had that more forward rather than retracted jaw. But I also noticed the bulbous uh, shape change in the backside. He had like a more like straight back side of his
Okay.
skull. And
Yeah.
over the 6 month of change, you could see this rounded formation on the occipital part of his skull that it
Oh.
had corrected and rounded out, which was like, that was one of the things I was like, well, that's so cool. It changed
Oh, wow.
his entire skull
Yeah. Cranium.
structure changed.
Yes. Yes. Wow. Amazing. Oh, you'll have to send that to me. I might like that. Yeah. Ooh, fun.
Yeah. Okay, Amanda, any questions so far?
No, I was just gonna say, like, on that, like, that's something, like, I still work in a traditional practice. And so for
Mhm.
so many patients, this kind of a conversation is like, whoa, this is quackery. What are you talking about? Like, just, I think there's a lot of the general public that are just, they're not here yet.
Mhm.
But there's certain things that you can talk about that they'll say, "Oh, that's interesting. Okay, that's interesting." And it can sometimes be really hard to start a conversation with a patient, with a parent of, "Hey, this is what I'm seeing," and getting them to get outside of the mentality that braces will fix this problem
Right.
at age 16 or whenever they decide they can get braces, because that's when they had braces. And not saying that speech pathology and orthodontics are the same, but I think there's a general perception of braces fix a lot of problems and straightening teeth fix problems. Does that make sense?
Mhm.
Yes, I understand what you're saying. Yes,
Yeah.
like you need structure needs to be addressed and you don't need to forget about function.
Mm-hmm.
Yeah.
Agreed, agreed. And I know, you know, learning all of this over the last year and a half of just like the concepts, even, after people get braces off, for instance, if teeth and tongue and lip posture is correct, you don't need retainers. That
Mm.
just blows minds. People are like, that's just crazy. And
What?
it's like, but it makes sense. It
Mm-hmm.
just makes sense.
Mm-hmm.
So I think for a lot of clinicians, it's hard to connect the dots of crowding as, hey, there's issues with tongue posture, there's issue with airway.
Mm-hmm.
It's finally becoming more of a conversation in the dental world of airway, 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 but
Right.
connecting these dots back to infancy of
Right.
breastfeeding, of how have they been trained to eat, to do
Right.
all these things.
Right.
So I
To
don't know,
chew.
what are good, yeah, chewing. What are good talking points for clinicians that maybe are on like, okay, this makes sense, but I have no idea how to start this conversation and maybe they're not supported by their practice.
Mm-hmm.
What would be something that you could tell that clinician to have a good conversation to a patient that they need to hear this?
Mm-hmm. Mm-hmm. Okay, so the default, okay, it makes me think about my books and why I created them. So I'll put a pause on that and talk about that. But to make the easy, most observable aspect of myofunctional disorders for the parents could be learning about mouth breathing, like observing and knowing that mouth breathing is occurring. Because when we look at our family members and our children, especially being, you don't notice that that's not what we want to be happening for the child. It's just what it is, and or they just have allergies, or this is just normal. Well, just
Yeah.
making it normal to talk about the fact that the lips need to be closed and we need to be breathing through our nose. It's you can visually see that. Um, it doesn't necessarily take care of what the tongue is doing all of the time, but it's at least a start, right? It's at least the tongue has the chance of resting on the palate if the mouth is closed and the tongue is not, hanging down. So I I have some orthodontists and some dentist colleagues that actually have my book sitting in their treatment room or
Mhm.
on. And what happens is while they were waiting and they pick up the books and the kids are interested in them, it kind of, as I wrote them, there's a part that explains it in very interesting, fun for the kids, but very informative for the parents why what needs to be happening. And so it's like if they're told in a very, fun way or just be able to notice it and the books are just there, the parents might ask about it because you're bringing awareness to the parents. Oh, well, my kid's not breathing through their nose. So it's that. And also, like, I think if I was in an RDH in a typical practice, the two things I would bring up, um, it that doesn't is not necessarily supporting myofunctional therapy at this point. They will. We know they will, but at this point, I would talk about the mouth breathing and hey, can you observe your kid and report back to me the next time we're together what is happening when your kid is watching TV or when they're on their phones or playing their switch game? Is their mouth open? Are they breathing through their nose or not? And then back to the chewing. Are your kids
Yeah.
chewing? Those two simple things can at least, and then I have started, like, I volunteer at a place for kids with Down syndrome, and I've started to talk to the parents, like, look into like oral rest postures. There's a lot of information about that out there. Look at it, and then let's talk about it the next time I see you. Then they're the ones bringing it to you.
And
Um,
some of the other red flags that we see in kids or an adult
mhm.
could be the bags under the eyes, the dark
Yeah.
circles, um, bedwetting,
Mhm.
longer term is also
Mhm.
tied to some of that component, right?
Right.
Um, and that's because if we're not sleeping well and we are not breathing well at night, it keeps the bladder awake. And then
Mhm.
sometimes we don't recognize
Mhm,
that we have
mhm.
to go to the bathroom, and we have a kid that bedwets more often.
Right, right.
Right. Um, and then some of the attention deficit stuff. I this topic is like, and then crowding. Primary teeth shouldn't be touching each other. So if your baby teeth are all standing shoulder to shoulder, that's a sign that we're already crowded and we
Mhm.
don't have good facial posture. And we can use some devices. I don't know if you do these, but the myo munchies and things like that to
Mhm.
help start developing the face a little bit more, encourage that chewing habit um, for those components. But my kiddo, my oldest one, is 24, and she's got a deviated septum. She can't breathe through her nose. She was a bedwetter for a long time. She had attention deficit.
Mhm.
She had geographic tongue. She's
Mhm.
got huge tori now. I can't talk
Mhm.
to her now without, and her tongue tie is like so severe that
Mhm.
and in ortho, and we have to kind of talk about the ortho world because
Mhm.
I think we need to make parents aware of the different types of ortho going on and
Mhm.
what we need to
Mhm.
advocate for orthodontics. My orthodontist was like, well, we waited, we never expanded at all. And it was like, let's pull this tooth to make room for this tooth. Let's pull.
Mhm.
So we pulled most of her baby teeth because she wasn't losing teeth on
Mhm.
time.
Mhm.
Right. So those are all some of the red flags too
Mhm.
of what's going on. I wish I knew what I knew
I know.
now.
It's so hard, right? The things that we learned in school, the things that we saw in patients, we were just like, yeah, you just got to pull those teeth. And
Yeah.
now we know the function and what is really going on. And it's
Yeah.
like,
Now,
ah!
knowing what I know, I
Right.
wish when she was little, as a hygienist, I recognized we could have used, and she did breastfeed. So, she never used a bottle.
Mhm. Mhm.
But I mean, had I known, I would have expanded her. I would
Mhm.
have done the myofunctional stuff early so that she doesn't have the deviated septum and the tori and
Mhm.
the tongue. So it's so much preventative. If we teach hygienists to do an airway assessment, look at melon patty score, tongue
Mhm.
tie,
Mhm.
crowding as an infant, and start referring, at least recognizing those red flags, the
Mhm.
circles under the eyes. I have a hard time going to a pool sometimes and I can
Mhm.
see kids, I'm like, airway, or my kids are, in sports and I'm like, oh, that kid has an airway issue.
Mhm.
Once
Mhm.
you see it, you can't unsee
Oh,
it.
no, you can't. You cannot unsee it. Mm-mm.
It's so
Yeah.
recognizable and it needs to be taught in school,
Yeah.
because
Yeah.
there's lifelong
I bet.
repercussions for
Right.
it, like
Right.
sleep apnea and those issues. And once we get there, there's solutions for
Right.
adults. We can talk about, palatal expansion and MARPE and all of that, and we will.
Yeah.
We're going to have a dentist who's doing that sort of thing
Great.
in the future. We have her lined up, but you know, just orthodontists. Like, I'm super happy to hear that you're working with a airway functional forward, but I tell my friends, if an orthodontist tells you to pull the premolars, run.
Mhm. Yeah,
Do not do
you
it.
don't want that. Yeah. And as a product myself of, you know, an orthodontist that pulled my teeth because
Yeah.
they were crowning. I mean, I get
Yeah.
it. I know from like, and I'm like, oh my goodness, right? Oh my
Yeah.
goodness. It's like, when you know better, you do better. And it's
Yes.
our job to help people know better. And back to like if you had known as a parent, I was like my mission is like one book, one breath, one child, one breath, one book, one child at a time. It's like, from the ground up, like uh just talking about this as much as y'all are and explaining the importance of myofunctional therapy and how the function helps the structure and the structure helps the function. Like it's a teamwork. And
Yeah.
then, and then the buy-in from the parents about doing, and it's really difficult to have kiddos do myofunctional therapy, you know, carryover at certain ages. And it's like the
Yeah.
sooner we get them understanding that the parents that mouth breathing is important and the kids and everything and get the allergies out of the way and taken care of, you know, well controlled, then the
Is it,
lifelong
it
health.
I kind of know the answer, but do you think that the airway and mouth breathing, the symptom of the allergies and the sinus problems are a result of the breathing issue? It's a symptom.
Like mouth breathing is a symptom of allergies, is what you're saying?
I'm saying the allergies are a symptom of them. It's a result of them not
Correct.
using the sinuses.
Oh, I see. So it's even like the it's both ways. It has like
It's a pendulum effect.
Yeah.
yeah, I was going to say right. So nasal like stuffy nasalness occur makes you mouth breathe. And what you're saying is mouth breathing makes it even more difficult for your allergies or your nasal to get clear because mouth breathing isn't as healthy. You don't have the filters, the warming, the yeah,
Yeah.
it's a circle. And you know, in my world, and in my practice, it's like the typically usually the mouth breathing is caused by a nasal obstruction,
Yeah.
or a past nasal obstruction. So, for instance, if the family had a cat before the kiddo was born, and the cat was there during, you know, the first couple, 3, 4 years of life, and then the cat goes away. And then the child, even though the cat's not around and the allergy allergen is not in the house, the child has already practiced and developed the habit of mouth breathing.
Mm.
So then they could nasal breathe,
Mhm.
but they don't because they've learned by a past issue that caused an obstruction to mouth breathe. And so that's where I don't know if y'all are able to do this, but um, just testing with nasal breathing, whether or not it is a habit, mouth breathing is a habit or a obstruction. So there's
Mm.
that way where you can do like there's a study that they did with taping the lips and seeing if and I don't tape lips. I don't tape kids' lips because I have them just hold something that if they needed to, you know, like a piece of paper between their lips or a popsicle when we're doing this screening, because if they cannot breathe through their nose, they're going to get, you know,
Yeah.
it's anxious and it's not possible or healthy. But if they can keep their lips closed and breathe through their nose for 30 seconds, then add 30 more seconds, and then 100 up to 120. If they can do it for 3 minutes, then most likely it's a habitual mouth breathing problem, not a structural. Now, that could be habitual because they have severe allergies during the allergy season that are not well taken care of. So the rest of the time, they breathe through their mouth. I've had that in my practice many, many times. Um, or it could be that, like I said about the kitty cat when they were little and it's not around, but that's how they learn. Practice makes perfect, even if it's an imperfect practice.
Mm.
I love it.
Mm-hmm. Mm-hmm.
And the mouth breathing, I like the functional doctor and I talk about it because everybody with Bristol, there's a lot of people that come in from halitosis issues, and mouth breathing will definitely cause halitosis issues because it
Mm-hmm.
makes you dry. So if
Yeah,
we don't fix the mouth breathing issue, I might not fix the halitosis issue.
right.
But then the tonsils get swollen because they're our filter is our nose, not
Yeah,
our tonsillar tissue. So then the tonsils are mad because they're not designed to filter air, right?
right.
And then they get in swollen, and then we get tonsil stones.
Yes,
So I feel like if someone has an inflamed tonsils and they have the symptom of tonsil stones, it's most likely another sign to me that you're probably mouth breathing and not nasal breathing.
absolutely. Absolutely. Because yeah, if they both affect each other, it just makes the situation worse.
Yeah,
Yes,
yeah.
yes. It's like, yeah. I agree.
And then you get the postnasal drip that then irritates the
Yes,
the adenoids
yes,
and the tonsils. Again,
right,
this is super
right.
fun.
And then if you've got postnasal drip and you can't swallow in a vertical fashion, then you're just going to be swallowing more potentially, this way.
Yeah.
And this, making the tongue thrust swallow happen more. And then, wherever it's against the teeth, or interdental.
So let's talk about tongue thrust for a second, because that was my first aha moment on the tongue. I had a patient, went through ortho, and within 6 months of me seeing him post ortho removal, he was in complete open bite from tongue thrust.
Right,
And the dentist was just going to put him back in braces again. And I was
right,
trying to explain to the mom, we have a tongue function problem.
right,
If you don't do myofunctional therapy and fix a tongue thrust issue that's happening where the tongue comes forward and pushes the teeth out to make it so it was like flared
right.
in that from the tongue. And you can see that in a lot of patients if you have the flaring, if it for the general public, if your teeth are flared forward and your tongue is pushing against the front of your teeth instead of up to your palate, it's a super strong muscle that will change the posture of your teeth and cause open bite.
Mm-hmm.
And if we have that issue, we got to go see a myofunctional therapist and a speech pathologist to deal with the tongue function issue. And
Right,
I went round and round with the mom, and it was super frustrating because I was like, unless we fix the tongue, you're just going to continue to have this issue. I don't know where the habit came from. He was fine when we were in the ortho because the ortho were
mhm,
holding everything in and bringing
right.
everything else. But as soon as we got the braces off, he popped
Relapse.
open.
Yep,
Mm.
relapse. That's exactly what, that my co-presenting was about, anterior open bite relapse. Right. And, when I was speaking with Dr. Backow about this, she's an orthodontist in Seattle. And so specifically on open bites, right? So you are correct. And it's like, I have had multiple patients that are like on their second round of braces. And then, it was an opportunity for me to be working with that orthodontist and explaining about myofunctional therapy and bringing them into that world, which I loved. And, uh, tongue thrust. So a long time ago, myofunctional therapy was called tongue thrust, right? Well, we know it's more now than just the thrusting. So that's I call like because we have the resting of the tongue and how that affects. So it's a how it affects the teeth, and then we have the swallowing, that function part. So myofunctional therapy is about resting and function, oral resting postures, and oral function. So the swallowing happens throughout the day and it's kind of a stronger force, but it's very short and quick. Whereas the resting is long in duration and not as much in force. But each of them, in with the tongue being in the wrong position, can cause the teeth to open bite or flare, labial flare, right, of the teeth, and especially if the lips aren't able to keep it back. So it's again, it's like the structure and the function. We have to work together, collaborate for the patients, and educating the patients when their providers aren't um, don't understand the functional piece is very difficult. I had
Mhm.
that a lot in my practice. Have had that a lot in my practice. Not as much anymore because the people that are referring to me are the ones that are like on board with it. I am very blessed in that respect
Yeah.
at this. But I've been doing this, um, oh my gosh, for 25 years now, myofunctional therapy for 25 years now. So I've developed as we talked about, a community. Yeah. So yeah, it's tough. It really is. It's really tough. Mm.
Amanda, in your regular practice, do you refer to myo, or are your doctors aware with being more in a general type of practice? I mean, obviously they have you. so
Yeah.
that you get to have the conversation.
Sure, a
But
blessing and a curse.
eh,
So a slight backstory. So I work for a DSO. So we have specialists that come through our office, and I am on our third orthodontist, and I'm finally excited about him. He's fairly new, and he a little bit more doing expansion. He
Great.
uses those words. And then our company just decided to nix the orthodontic uh, program for us. I was like, are you kidding me?
Mm,
So I do, and actually, we are having a lunch and learn in our office on the 16th, I believe it is, with a myofunctional therapist in our community.
yeah.
So I have a newer grad. He hasn't even been out of school for a year yet. He's open to airway stuff. He's like, it makes sense.
Hmm.
So yeah, I mean, he's a fresh grad.
Great.
Um, so I think it will be nice for all of us to at least be aware of it because I know nobody else in the office is like ever maybe heard of airway. We do have a really great orthodontist in our community that I think does expansion, but not for airway purposes. He calls it like the Miss America smile, the nice wide smile, which I'm like, you know what? He's doing a good job. He's like hitting the nail on the head with reaching aesthetics in our community, but really opening airways as kind of a secondary effect of the aesthetics that he's after. So it's kind of funny. So I'm like, I'm fine referring to him for stuff, but obviously he's not going to be doing tongue posture there. I don't think he's doing anything with myofunctional or anything like that, but he's not just pulling and straightening teeth.
Yeah.
He's expanding. So
Wow.
anyway, interesting that you asked that question, Heather, because yes, we're I think finally going to be having a conversation of what airway looks like in our practice.
awesome.
Great.
That's exciting.
That is really great. And the myofunctional therapist, functional being, the operant part of the word here, will bring that how function helps with airway and how, because that's like, because it's been so interesting to me. And I've been doing a lot of research about the tongue rest posture, right? And the different disciplines between the speech language pathologists that are myofunctional trained and the RDHs that are myofunctional trained, and how they talk about the tongue rest posture. And in fact, I'm in doing a research. Yeah, I'm doing some search in the perspectives of different perspectives of the different professions on rest posture, right? So it's like uh, how you describe how the tongue should rest has two different camps, so to speak, about it. One with like speech and swallowing kind of way of holding the tongue, and the other is like kind of the airway. And it's so interesting
Mm-hmm.
to talk to hear, like, like about like specific like airway, and then there's airway, and then it's like there's airway, there's oral function, and there's oral rest. Does that make sense? I'm starting to
Yeah.
wrap my brain around the fact that, okay, so resting posture is a thing, and we have, different descriptions of how that should look in the different camps, whether and then function, oral function, and then airway. And they're all connected, but it's like,
Kind of how they view the importance of the tongue and what it's doing.
yes,
Hmm,
yes.
I can see
And
that.
and how to relay that to your patients.
Mm.
Like, because no matter what, we have to think about, and my mentor always told me about this, the capacity or the capability that that person in your chair has. Like, they might not be able to get the back part of the tongue up or the mid part, the lateral. But like, hey, we get the if they can get the tip and then the little bit of the lateral edges, then you're way better off than if you weren't even talking about the lateral edges of the tongue resting on the palate. Because I talk a lot about that with the kiddos. And in my book, let me pull this one out. Miss Tongue Learns to Rest. there is a picture of, let me see. So Miss Tongue, like rest, can y'all see that one really
Yeah.
well? Miss Tongue resting her head on the pillow. So that would be the tongue tip to the spot, right? But I make it very clear and important in the book that she needs, can you see that page?
Yeah.
Mhm.
She needs to snuggle, which means the lateral edges of the tongue need to be resting against between the teeth and the dental arch, the palate and the dental arch. And so that is super duper important. Now, can the kiddo or the individual actually rest the tongue in that position, all of the tongue in that position? We don't know if they can, but can they do some of it? At least getting the tongue up there and as much of the tongue tip and edges resting against the palate is going to help that tongue stay up rather than down in the mouth, which will help with the tongue falling back in the mouth.
I love that. So
Yeah,
let me recap this and how I took that
please
information.
do, because I'm just starting to
So
talk about
the
this.
tip of the tongue is Miss Tongue's head,
Correct.
and
If I
she is supposed to rest right behind, her head should be behind the front teeth at the hard palate right at the top. So
right on
can
the
you get your tongue resting on the pillow? So is your head on the pillow or is your whole body in bed on the palate? Right? Is that what you're saying?
Well, because I so the pillow is on the incisive papilla,
Yep.
right? That's where that kind of little play on words came from. So specifically to in speech, okay?
Yep.
We have to have the tongue braced, okay? So that the tongue will stay within the mouth and not, like, say for S sounds, lisping, like
Yeah.
the movement. Okay. So there needs to be bracing of the tongue at the back for the tongue to be so it's active and braced at the same time. So there's stability and mobility of the tongue. Same thing happens when we swallow. There has to be stability and mobility for the swallow. So for a kiddo to maintain, right, a lingual palatal suction or suction that tongue up all the time, that's like not very natural in a sense because it's like lingual palatal suction is a great exercise, a great way of teaching awareness and what. So I'm not saying that the tongue isn't like uh slightly suctioned up there because there's going to be that, but it's like trying to have someone who doesn't have the palate width and whatever smush that tongue up there and keep it up there all the time, especially if there's like the frenulum is pulling down. That's going to be really, really difficult, right? So meeting the patient, and this is what oral facial myofunctional therapy is like teaching someone therapy, teaching someone and motivating someone to do something they cannot do, right? They can't do this. They're not, that's why they're in myofunctional therapy. So meeting them where they are, can we elevate the tongue tip? And then can we elevate the sides of the tongue and rest it up there? And then move into the swallow, move into the speech sounds, make it functional. That is part of myofunctional therapy. That is the function. And I understand like the airway piece is what is the back of the tongue doing,
Yeah.
right? What is the back of the tongue doing? So it's like resting, functioning, breathing.
Yeah.
But all of them are important, especially breathing.
Mhm.
So I know this is it's like my brain has been processing all of these perspectives and differences, and that's why I'm having this, like, how do we put it together in the way people can understand it
Yeah.
that are new?
Which is why you started your book series. So let's dive into it. You gave us a little taste of Miss Tongue and where she goes to bed.
Right,
But
right,
tell
right.
us about all the different books you have and why they're important and maybe having them in our waiting rooms or somewhere where
Yeah.
kids are or adults are exposed to it so that we can start having those conversations. And why are they useful to have? Tell us, you know, I think it'd be awesome to have it in schools because
Yeah.
Right. And
um
I'll say one of my projects I'm working on is that exact thing. So like when I wrote these are these books. So I have Miss Tongue Learns to Rest. Okay. The Lips Learn to Stay Together, and Mr. Nose Learns to Breathe. Okay, so these three right here are what I call the Healthy Functions book bundle. So if you can buy them individually, but all three together, they really put together all the pieces of the puzzle, right? And so these are, you know, 3 to 6, 7, 8, like I have an 8-year-old right now that he's reading the books to his younger sibling, right? And he likes them. So it's like, it's kind of in this realm like this. So I'm writing, currently getting illustrated. It takes so long. Oh my goodness. The books for the elementary school and how the school speech pathologist can connect this with what they are focusing on, which is the speech sound production. Okay, so I'm working on that. But Mr. No, like the Mr. Nose has secret superpowers, which is breathing that the mouth doesn't have. But what the other book is talks about the cilia, it talks about the healthiness, it talks about the jaw. So I can relate that to a more technical for the older kids. But I also have ebook. So I've been getting international purchases, so I have had to make them in ebooks. So I made another ebook called Miss Tongue's Resting Adventure. So it just goes through, and Miss Tongue is resting while she's baking cookies, and Miss Tongue is resting while she's doing crafts, and it's really cute. It turned out really well. So the resting adventures of the staying together of the lips adventures and the nose superpower adventures are on in process. But so those will be out in ebook form. But the other one I have is Miss Tongue Learns to Dance. And so this one is for the kiddo who is going to need a lingual phrenectomy.
okay.
And it talks about, so it starts off with, so it explains all the dance moves and how they are a functional movement or a pre and post phrenectomy exercise, so to speak. And so it starts off with Miss Tongue because she's stuck like
Can
bubble.
you could you
Oh,
take your oh yeah,
oh,
you have a
yeah,
background like blur so then it blurs out your book. Yeah, that's awesome.
there.
That's
So
fun.
she's stuck like bubble gum on a shoe. She can't dance like all the other tongues. And so it goes through the process. She finds a helper, which is the doctor that's going to help her. And then she can do our dance moves. And so, and all of these books are like, oh, Miss Tongue, like to take the pressure away from the child. Like there's nothing wrong with you. We need to teach your tongue this trick. We need to teach her tongue to rest. We need to teach her nose to breathe. We need to teach her lips to stay together. And so this one too, it's like teaching. So they read about Miss Tongue or Mr. Nose and what their job is. And then now, can your Miss Tongue do this? Can your Mr. Nose do this? And so then there's celebration at the end of the book because your Miss Tongue is resting and your Mr. Nose is using his secret superpowers. So always in my treatment with the kids, I was always like, oh, tell your brain to tell your tongue to do this. Let's tell your brain to tell. So it's like uh, a teamwork. Like we're helping your tongue learn this, and so that's how these books came to be. And I used them in my practice, and then the pandemic hit, and I'm like, well, might as well try to print them and
Yeah.
illustrate
Heck
them.
yeah.
And so here we
Good
are.
for you. That's awesome. It's February is dental health month and there's so many hygienists that are going into practices and someone was posting like what should I do for like anyone got some book suggestions and I was like Miss Tongue.
Okay. Yeah.
I like let's talk about something different than just brushing for a moment. Here, check
Yes.
Right.
out these
Yes.
series.
Oh
So
my.
hopefully it introduced the concept to some other hygienists who maybe haven't really thought
I
about thinking about reading that to the group.
I I love it. I love it. And I actually have, I'm going to post it very soon, but we already have it in there. I have a February coupon code for 10% off. And I'll tell I thought, oh, this is what I was thinking in the beginning. I wanted to tell you, tell your audience is Cupid 10.
Cupid 10.
Cupid 10.
Cupid 10. So if you put in, like when you go to my website, misstongueandfriends.com on the products page, it asks, if you have a discount code or whatever like that, and it's Cupid 10.
Okay.
And
And
so
that's good for the whole month?
February. Mm-hmm.
Okay.
Yeah, yeah. So there you go.
And
And
we can link her in our in some of the when we post, right?
Mhm.
Awesome. Perfect.
Yeah.
yeah.
I'll
Excellent.
add that in the show notes as well as on the YouTube description.
Awesome.
Great, great. And I have an Instagram at Miss Tongue and Friends, right? And then that goes to a Miss Tongue and Friends Facebook, right? And I'm on LinkedIn, kind of. I'm like trying to
Yeah.
keep up with all
I think
of them.
everybody's kind of on
Yeah,
LinkedIn.
exactly. So, but anyway, yeah. So, and I on my link on my Instagram yesterday, someone did one of the most amazing posts, and I had sent it to y'all because I was just she put into words what I exactly wanted to happen with these books and how I want them, because as a therapist and a myofunctional therapist doing this, I've been doing it for years, and I like can reach patients one at a time, but I love this opportunity to reach more patients and earlier.
Mm.
Back to what you said, Heather, and I have taught in the area and supporting school SLPs and how we can bring myofunctional therapy and then the information with it that they can use underneath their guidelines in the schools. So
Awesome.
it's all there, and I love
And
it.
I have to say, like, I have this conversation all the time. I feel, and I've had enough test results now from the little kids who get dental decay issues.
Mm-hmm.
Dental decay issues have a lot more to do with breathing and mouth breathing and dry mouth issues and diet than they do the strep mutans and the bacteria. I have kiddos who have no bacteria in their test results, and I teach this in Bristol. You
Mm-hmm.
don't have to have the bacteria that causes
Mm-hmm.
decay in there to have
Mm-hmm.
decay issues. And with the little people, it's usually an airway signal.
Yeah.
So
Yeah.
if your little one has a lot of decay issues, look at crowding, look at airway, look at facial posture, look at your mouth breathing
Breathing.
component, and fix the airway early. Use a
Mm-hmm.
myofunctional therapist, use a myomunchie or something to start developing the face and expanding the facial growth. Look at
Mm-hmm.
nutrition, because it's not always the bacteria, it's oftentimes function and
Yes.
nutrition.
Yes, yes, I agree. And can I say one other thing about how I would use Myomunchie as well in my practice?
Yeah.
It's also great for lip closure and nasal breathing,
Yeah.
because like if the kiddos, like you can use it for the chew, what it's intended for too, and it's a great way to put, to have it be part of the lip closure nasal breathing, because again, it's a physical reminder in the mouth that is not normally there to keep the lips together and breathe through the nose.
Mm-hmm.
With Myomunchie, I have a couple questions with
Mm-hmm.
Myomunchie and some of the other devices, because there's a few of them out on the market now. Um, but with Myomunchie, I think of littles, right? I think of the little kids starting in that process. But is it something adults use, and is it useful for adults to utilize?
I have not used it with my adult patients either.
Okay.
I have used it with the littles for
Yeah.
exactly what you're talking about. I think in my uh, world of working with adults, I usually will give them um, easy physical reminders that they can use instead of the Myo Munchie, because like the myo spots, I've used that with patients because they're talking all day and they have this reminder. I use the dental elastics. I will have the kiddo, the adults. You put the a dental elastic, like the 1/4, I think it's the fox or whatever, like that. It's called, the character on the tip of the tongue, like literally hanging off the tip of the tongue, so they won't press against the teeth. And then they put it up to the incisive papilla. So let's say they're in a meeting and they're concentrating on the meeting. If they have a physical reminder in their mouth that if they let their tongue down, it's going to fall out, then they can sit there with the elastic in the mouth. There again, we're just talking about the tip of the tongue right now, but elevation, progress, not perfection, right? But if they have that up, and if they are swallowing and able to swallow during that time period and keep it up there, you're going to have like the tongue tip squeezes. So the saliva is going to go on top. The lateral edges are going to seal the saliva so that it goes back and is swallowed. So that is a simple, easy device.
Never heard of a tongue or the elastic. So
It's
can
an
you
ortho
elaborate
elastic.
a little?
It's just the little ortho bands, right?
Oh, ortho
Yes.
band. And then
Yeah.
what he's doing with it?
So
She's putting it on the tip of your tongue and you hold it on the roof of your mouth. So it's just that reminder.
Okay. So you're just holding the elastic on the tongue. Okay.
Yeah.
mhm. So it's
I know.
like,
At first, I was like, what's the
what's she
appliance it's
talking
being held
about?
to? So it's just a very out of the box use for the product.
Exactly, exactly. And
Yeah.
let's say the adults they have braces, right? They may already have the elastics or the kids, but I have people who ask people who aren't in braces at this point, buy these elastics, get them from your orthodontist because your tongue will have it and it'll rest right up there and you won't forget
Yeah.
that what your tongue is doing when you're in the middle of a meeting or something important. If you don't have to talk, you're on a Zoom call. It's a perfect time to practice it because you have a physical reminder, tactile physical
Interesting.
at that point. Mm-hmm.
And
A lot of tips in my jar about what to do.
and is it a big deal if there's just if the head is there or is the whole body supposed to be there? Because I have a posterior tongue tie. And I can't suction my tongue to the roof of my mouth. I can get the tip, no problem. And I know enough now that I do practice keeping my mouth closed and I do keep my tongue to the roof of my mouth and those
As much as you
protective.
can.
But
Yeah.
the back side of my tongue, it's just hanging like this.
Well,
Am I
and
supposed to try to get that up? Because that would make my tongue really tired.
okay, see, and that's what absolutely not. You cannot do that, nor do you need to do that, nor can the kids do that all the time.
Okay.
No, with the tongue muscle. Okay, let's do a demo here. Okay. All right, let's do this. All right, so both of you put your tongue tip on the incisive papilla. Okay, close your mouth, and then we're going to do a swallow sequence. Okay, I'm going to describe it and you're going to feel what happens. Okay, so, all right, so saliva is pooling in your mouth, I hope, if you're not too dry. All right, so for this practice, put your back teeth together if you can. This is not what we normally do, but this is a swallow sequence. Back teeth together. Now squeeze the tongue tip on the incisive papilla and now swallow. Okay. All right. See, I see this. And I see. Okay. Let's start with Amanda first. Amanda, and do it again if you need to. What did you feel, notice, observe? Tell me what happened.
I feel like the saliva went to the very middle and then my tongue was just like, oosh, go down.
Exactly. Okay. So what happened in Amanda's mouth is that, okay, so the tongue's like this. Here's the palate, right? So the saliva that was pooling down there got suctioned up, okay? Intraoral suctioning, suctioned up. And then her tongue did this wave-like motion, okay? So squeeze up and then down for the liquid to go down.
Yep.
Okay. I could see
I
she
do not have that.
right. She had it.
I got one thing.
I can diagnose both of you right now. It was easier for her. It was very easy. She was just observing what was happening. You struggled with that. Right. And so the point with this is in your case, capability, you keeping your tongue tip up and as much of the lateral edges of it that can stay there, and your lips closed and your mouth together is golden for you. Her Amanda's capabilities is just textbook. I can do this. I can do this all day. She doesn't even have to think about, like, Amanda, when your tongue is resting on the roof of the mouth, what contact of the tongue can you feel, and where do you feel it?
Pretty much everywhere. I'm not as aware of the tip as I am the posterior. Like I have scalloping along
Okay.
my lateral edges, so
Okay.
I pretty constantly have suction up there.
Suction. And so suction meaning the back lateral edges, or your whole back of your tongue is up?
I say the whole back feels up.
It feels up. So, and is it making contact with your palate?
I have maxillary tori, yes.
Okay, so of course it is if you have maxillary tori. Okay,
Yeah.
so for her structure, shape, and whatever, the back of the tongue being up, and it feels like it's more up for her because she has the tori. Now, if she did not have the tori, that tongue was not going to feel like it's pressing up against the palate, possibly. But there is tissue, bone, there is structure there, so she feels like the entire back of her tongue is resting on the palate, which it is. Like, none of us are perfect, right? None of us are
Mm-mm.
perfect. You, I mean, Heather, on the other case, is like, I want you to tell me what you feel.
Like the top third,
Mm-hmm.
the tip
The
and the
front third,
third front are
yes.
there, and nothing's is just like down here.
Right, right. And so when I talk about the tip of the tongue being in that spot, that's for treatment. Because technically, after you get to where this is a resting position, the the amount of tongue that's resting up on the palate, if the palate is low enough for that to happen, right, is going to be the tip and part of the blade. Okay, just like you're happening. And you're so it's not possible for the back of your tongue. Now, what you don't have, which is great, is there is some bracing of the tongue in the back when you speak, because your tongue is not flying out of your mouth when you speak. So you have lateral edges that are making contact with what, like in my mouth, I have to work because I have a narrow palate. I have to work to keep the tongue from, whoa, sorry, from seeping out here from
Yeah.
in my mouth. But it's because I've been doing this forever, and I know, like, I smush my whole tongue up there and it's fine. But there is, so when do a swallow again for me, and I want to see, yeah. So do you feel the tip, the blade of the tip and the blade and some of the back edges making contact when you swallow?
Um,
Or no
I
back?
have the edges that are making, but the back of the tongue is all messed up. Like
Well,
it
it's
doesn't
supposed,
want to force anything down there.
yeah, and it's the back of the tongue is supposed to lift and then allow, but yours is not lifting enough to make it comfortable to
Yeah.
do, yeah,
Mm.
yeah. But
Yeah.
it's functioning, but
Yeah.
it's not as flexible, just like myself. Yeah.
Yeah.
Hmm.
Yeah. And I'm
Yeah.
class 2 division 2. And everything. I've had braces twice with
Yeah.
um yeah, Invisalign, which
Invisalign.
I
Yeah.
don't love Invisalign.
No.
Yeah.
I, I don't, it's interesting. When I was going through my myofunctional training, I called up my orthodontist. So in my structural, I have a very retracted jaw, right? And so I was 8 years old by the time I got to orthodontia after the dentist pulling out a bunch of teeth, right?
Mhm.
And so he gets to me and he's like, I get to them, he goes, well, I don't know. She's 8 years old. She's on this growing thing. I don't know how much of this that we can handle. So he put a bionator in. Do y'all know what that is?
No.
It was this device that I had to bite down. And so that it was a wire here and something plastic at the bottom, and we had to twist it.
Oh.
And it was,
Oh, yes.
yes.
Okay.
Oh, so I mean, I'm showing my years here, but anyway, we had to twist this and it would pull. It was painful. It was pull. And he actually had me, when I didn't have the binator in, he had me holding a Cheerio and holding my tongue tip up to the
Huh,
incisive papilla.
huh.
And this was like, okay, 50 something years, well, less than 50, just less, years ago. And so, point being said, and braces one time, right? Just once, retainer, little bit, right? So I'm going through myofunctional therapy and I go to him, I'm like, um, I don't know how you made all this possible given what you had to work with and the fact that I have this tether in my mouth. But wow. And he's like, because now he's following me of like what I've been doing. He's like, yeah. And he's like, Tricia, like it was a thing, and you were like barely getting through here, and I didn't know if you were going to be able to move, and you did a little bit, right? But
Mm.
but airway wise, I don't have tonsils and I don't have adenoids. These were taken out when I
Yeah.
was a child for issues.
I have an
That's
expansion question
interesting.
because now that we're on kind of some of the ortho stuff, even with the adult stuff, with the MARPy stuff, I think about like, okay, now we can put in a MARPy. Let's just define a MARPy. Is adult expansion. In little kids, we can start expanding young because the suture hasn't necessarily closed yet. So it's best to develop the face when younger because the bones are still growing and we're not fused together.
Right.
So we can expand young easier, and that's the best.
Right.
um and then now we have things like a MARPy or other devices that we can basically put implant screws into the palate
Mhm.
on either side of the suture and sometimes surgically open the suture, or we can forcibly open the suture through cranks and pulling, and
Mhm.
it cracks the suture essentially, and we're expanding. My question is this: we have a lower jaw in
Mm.
occlusion. How does it all work with like expanding the upper and then getting the occlusion correct with the lower jaw and fixing, like getting proper function and occlusion that way? Does it automatically fix that way? Like I I remember sitting in a restaurant a couple months ago and there was a kid that I was super happy he was getting expanded. But holy cow, I looked at his mouth and from like halfway across the restaurant, I was like, he's so expanded that his jaw was literally
Oh.
not in alignment at all. Like I could see like his mandibular jaw, his teeth were inside the
Hmm.
upper, and I was thinking, boy, like how is that all gonna come together? So like
Yes.
that's kind of a messy spot too. Like how does the jaw on the lower deal with the expansion on the upper?
Right. In an adult or yeah, and this is going to be a great question when you have the orthodontist that talk about
Dentist?
the
Yeah.
MARPy. Yeah, the dentist about the MARPy. I do know that there is like they like for the instance, my patient right now who's having the MARPy and he just got the lower braces on. So there is a not as the space or the amount is obviously not the same as allowed on the maxilla as the mandible. Okay. But there is also like ability to like
Tilt out a
tilt
little.
out.
Okay.
And so that's and I've had it explained to me by an orthodontist that are doing it, but I'm not going to do any justice to explain it the
I
way that
love
they
I
can.
love that answer because I always
Yeah,
say if
because
I don't know the answer, I'm not going to give you
yeah,
an answer.
yeah, I'm
Perfect.
not. So I
Yeah.
do know, and I look forward to hearing about what the MARPy specialist talks about because it is fascinating to me. And with
Mhm.
this particular patient, I sat in on most of his orthodontist works because I doing this as a favor because they're all connected and they want me to help. And so it's fascinating and
Yeah.
I'm learning so much. But yeah, I'm not gonna go
That's
into
fine.
it.
I love that. I
Yeah,
think when we don't know the answer, we shouldn't answer. So
right.
that's perfect. It's just something that crosses my mind, and I remember thinking to myself, I don't know how this kid's chewing
Right.
right now.
Yeah.
Because
Yeah.
and
He still is going to have some growing capacity,
Yes.
though.
yeah,
And that's the thing
the-
with kids.
yeah.
They
And I
will.
feel like if you make the space, like, because I am retrognathic, I have TMJ discomfort.
Yes.
I honestly feel like if I could just put my jaw forward a little bit beyond my teeth, it actually feels so much more comfortable in my muscular system.
Yes.
But
Agree.
my jaw is forced back because of my retrognathic uh face,
Yeah.
right? So sometimes I feel like, well, maybe what can happen is the jaw then can rest in a better muscular position where then your jaw kind of not necessarily appears bigger, but it's actually going to rest in its natural spot better and align with the teeth a little bit better in
Oh,
that. Does that make sense?
yeah. And honestly, like I think that's what my orthodontist did for me
Yeah.
way back when
Yeah.
but because I still had the ability with the growth. Like,
Yeah.
I was just on the cusp of that
Yeah.
happening. But in our cases now, it's like you can't like help the growth. It's I think that, and that's why this is
Early
why.
intervention is so
Right,
important.
right,
Wait,
right.
you mean don't wait and see?
Don't wait and see. And like, to answer that, it's like I want like the parents and the RDH is like, trust your clinical and parental guts on this, because you're seeing something. There is information out there now, and honestly, if you get to a myofunctional therapist, then they have resources of orthodontists like myself. This is how it was for me, like orthodontists that are in line and I work with, or an ENT or an allergist, or it's like a myofunctional trained professional is like the hub, and you have all these little parts of the wheel that then creates this whole healthy structure as best as you can from where you are. Like, just make it as best as you can. Nothing's
And
perfect.
that's where collaborative care is so important.
Yes.
I
Mhm.
have something I really want to ask you, and we'll connect on this after. But in my saliva sleuths community, I am putting together a referral list. And what
Mhm.
I'm trying to do is get um, myofunctional therapists listed in, functional minded, airway minded orthodontists as a
Yeah.
list of references, functional doctors, functional nutritionists, and then biologic dentists.
Yeah.
I I love biologic dentistry. So,
Yes. Yes.
but working on a network, my challenge is I feel like here in Wisconsin, I just don't feel like we have a lot of resources for that airway ortho aspect.
You're right.
And honestly, like I work with people across the country, and
Mhm.
just finding a myofunctional therapist is a challenge because there's not enough. So, hygienists, if you're interested, and this is a really interesting conversation for you, I highly recommend that you look into a myofunctional therapy program because it's much needed
Mhm.
in the field. Because I can't find someone in like the New Hampshire area.
Mhm.
There's certain spots that I'm just like I have, and we don't have to be in the local area to work with someone because you can do a lot virtual. But I do like referring locally because if we need a frenectomy or if we need to an
Mhm.
orthodontist, I like you to be locally connected within the
Yeah.
community to be able to have those other collaborative relationships, a myofunctional therapist working with the dentist on the frenectomy part, or the orthodontist on the airway component, or a
Or the body
chiropractor.
worker.
Yeah.
Exactly.
So I
All of
think
that.
that we need to have more resources for that. So if you have a list of individuals that I should be putting in my referral section, I would
Yeah.
love for that, because the saliva sleuth is all about sleuthing on the oral microbiome and talking about all of this and educating in that component, but also making sure we have a community of individuals for collaboration. And
Yeah.
we're really lacking the resources. I have to Google like myofunctional therapists in this area.
Mhm.
So the more we can get resources out to individuals, the better, and have trusted collaborators, I think the healthier we can have our patients.
100% agree. And this is like it's obvious this is your mission. Like one of your missions is this. Like and same with me is and we're approaching this. I love that we can like bring it all together and we're approaching it in all different aspects and ways to get the message out there. So if the parents might know about it, then they can like ask their providers, and if the providers know about it, they can tell the patients, and it's this win-win whirlwind that we're trying to create of
Yeah.
collaboration and connections. And yeah, and it is hard, and I agree. In some cases being able to do myofunctional therapy virtually, and but if you don't have the other support, then it's just like if you just have braces
Yeah.
and you don't have the myofunctional support. If you have myofunctional, but you don't have the structural point or the allergy support or allergist or body work, it's hard because it's all a part of a team, collaborative team.
This has been an
Mm.
amazing conversation. I
Oh, I've enjoyed
really
it.
appreciate you
No,
coming.
it's super great.
Yeah.
I would love to get Tricia just like a takeaway that you would give to either clinicians or a parent that's listening about what our conversation was today, just as some sort of a takeaway for us.
Yeah. So I think collaboration is a key takeaway from this because I'm coming as a myofunctional trained therapist and a speech pathologist at that, and y'all are coming from the dental world and specialized in your own aspects, and so like collaboration and understanding of what the knowledge and perspectives of the other disciplines benefit so very deeply our patients, and it is so very essential. So collaboration and just knowing that yes, there is something that we can do. Something. It doesn't have to be a perfect structure or a perfect function. Just something is better than nothing in what we do for the patients and for them.
And then we always love to ask, what is something that you're learning and something that you're reading that you would encourage others to do as well that are interested in this topic?
Oh, okay. So I just purchased the book, oh, Behind the Smile. He's from Australia, oral facial biofunctional dental in the dental world. Yeah, his name's Donnie Oh, God, I wrote this down because I wanted to be able to tell you his name. Um, it's yeah. Okay, just give me a second. Oh my God, where did I put that?
It was Behind the Smile.
Yes, it's called Behind the Smile. Did you find it, Heather?
Um, there's a couple of them in here.
His name's Dr. Donny, Donny, from Australia.
Is it Behind the Smile Dentistry for Children? No, that's
Nope.
not it. Nope.
Oh, let me pull this up because it is like I am so excited. I was just in touch with him about I'm so excited to read his book.
Donnie
Yes,
Yeah,
that that book.
Mandra.
I was trying to pronounce it. Yes. So he is, like I said, he's in Australia and he just published this book and I just got it. And I am excited literally tonight to read it. And what am I learning? Um, let's see, what am I like? I am really learning about, I'm very interested in how I can talk to and communicate well language wise with the dental community. And so that's what I'm doing a lot of. I really enjoyed that co-presenting with an orthodontist and how we are like a team. And so I'm doing a lot of listening and collaborating with the dental world here.
Yeah.
And we're starting a yeah, a little study group, local study group. So yeah. That's where, in addition to, oh my goodness, Miss Tongue and Friends, all the things that I'm learning to write those books, which is a lot of
Sure.
learning. Yes.
Yeah.
The business side of things is always kind of the scariest and most exciting when you're in this kind of a space.
Yes, yes. And
It's
writing, there's so much that you need to study and learn in writing because you have one chance to explain it, and that you don't want to blow it in the printed word, right?
No pressure, no pressure.
No pressure at all. So yeah, oh my goodness. That's why it took me 4 years to like actually put Miss Tongue and Friends together, right? So, but now it's getting, it's got some momentum. But thank y'all so much for this lovely conversation. And I can't wait to hear it more from y'all's podcast. I really
yeah,
can't.
thank you. We appreciate you coming in and starting the airway conversation. There's a few wants of different people that I really want to get on the podcast and have more in-depth conversations on the airway. It's something I teach, like you have to, we have a triangle. We have the airway, the oral microbiome, and the gut. And we just can't fix people unless they're looking at the whole triangle. So it's all tied together.
I love that. I do. I agree. It's so important. I know.
Thank you so much for your
Thank
time.
you. Bye bye.